Hello and good evening, and welcome to a series of critical conversations that we're having around health and development on Scroll in partnership with Survivors Against TB and Pi Consulting. My name is Chapel Mehra. I'm a public health specialist, and today we will be discussing the long-term implications of understanding and living with COVID-19. COVID-19 has redefined what we call the normal in society, in countries, and in our health systems. We are currently faced with living with this health crisis over the next 6 to 12 to 18 months, if the WHO is to be believed. And as we grapple with this crisis, as the world grapples with this crisis, it's time to take a step back and understand some of the key challenges that we face, but also to understand in detail the strategies that have been implemented, tried across the globe, and what we can learn from them. This is probably a great time to pause and reflect and look at understanding what has worked, what hasn't worked, and how we can move forward and live with this virus over the next year at least. So without further ado, let me explain the format of the show. Um, this is a show which has two experts today. We will be taking live questions. Usually, this show is bilingual. We try and do it at least one Indian language, that is Hindi. But today, our panel of experts will not be able to speak in Hindi. So wherever possible, I may try to paraphrase and reflect some of their views, with due apologies to them. About what they are saying. But before we jump in, let me introduce my very esteemed panel. The first we have with us is Professor Michael Baker, Professor of Public Health from the University of Otago. Welcome, Michael. Um, and he has been one of the key advisors to the government of New Zealand on the elimination model that New Zealand has implemented. There is a great deal that the world can learn from the work that New Zealand is doing, and we're looking forward to exchanging and understanding his perspective on what other countries, especially LMICs or low or middle income countries, can take from that model. My second panelist is Ramanan Laxminarayan, a well-known epidemiologist. He was welcome, Raman. He was the person who earliest did the modeling on how COVID-19 would travel across India, what would be the caseload, and what would be the possible mortalities. Many people at that time thought it was an overestimate, but as the caseload rises across India, it is time to actually look back and ask him some of these questions about what led to this modeling exercise, what are the key elements, and how do we progress from here to address this crisis in countries like India. So let me turn to you first, Michael, and ask you this question. There's much talk about the elimination model that is being implemented in New Zealand. It's being studied across the world. You've been involved in it. What are the key elements of it, and what can we pick up and understand that would be relevant to countries fighting COVID-19?
Well, greetings from New Zealand, and it's a great pleasure and an honor for me to be in this broadcast. And as we all know, we're all in this together, and it's really a great opportunity to share experiences and what we've learned tackling this really terrible foe that I think none of us predicted. In New Zealand, we were really following the standard pandemic model, which is really for influenza. And I think because of the threat of influenza pandemics, most countries in the world, supported by the World Health Organization, developed plans that have a very similar broad approach. And it could be described as a mitigation model because you can't contain pandemic influenza at present unless you are perhaps an island state that can shut your borders entirely, so lift the drawbridge. And that has a history of protecting particularly island states in the past, but it's not really it's not a viable model for larger countries, particularly those that have borders with other states. But we had a few, what you'd say, these light bulb moments, and I guess clearly this was going to be a pandemic in January, but in February there was really the remarkable report from the joint mission to China, the World Health Organization mission, that noted that really China had done a remarkable job of containing this pandemic in full flight. And so that convinced people like me that actually there was no biological barrier to stopping this virus, this pandemic. It all comes down to, I guess you'd say, the will and the infrastructure you have. And when we started, we were getting cases in February in New Zealand, and then by March it was switching from being an imported disease to local transmission, community transmission. At that point, I guess the third, what I'd say would be a light bulb moment was, for me, was the fact that we could not contain this virus we knew it was containable, but we couldn't contain it with the infrastructure we had. We didn't have enough contact tracing or testing. So really, I was one of the people who advocated very strongly for a very intense lockdown, which the country went into later in March. And this was very intense. Effectively, the whole country went home and stayed home for 6-7 weeks. So it was home quarantine for 5 million people. And that achieved a number of things. Basically, it extinguished chains of transmission, most of them. It gave us time to build up our testing capacity and contact tracing. And thirdly, it gave people in the country an understanding of physical distancing, which we'd never experienced a pandemic before. We weren't affected by SARS. So the end result was we came out of lockdown into a virus-free country, and that's how we've been for the last 5 weeks. No circulating virus in the country. We have had one or two scares with the border quarantine, like everyone has to go through 2 weeks of quarantine coming into the country. And we did have we are getting a number of cases identified in quarantine, but they are not actually, even though they're added to the daily total of cases that we report, they're not cases of transmission within New Zealand. So we have really met all the criteria we have for elimination, just using those 3 simple methods. So that's just an overview. I'm very happy to discuss the different elements of that strategy further.
Now, this is really helpful, and congratulations to you and your team for achieving what the world is still grappling with. Raman, you've heard Micheal talk about this. Let me sort of, Ramanan, ask you. You were the first to project the large-scale spread of this virus, and you did a modeling exercise which took Indian factors into account. It was a model that was highly adjusted to the Indian conditions. Tell us a little bit about your projections, and as the case load rises in India, what should we be expecting?
Right. So the story in India was very different. Well, the timelines were not very different, but March 12th or 13th was when we had the first death. And typically, when you have a death, you typically would expect that at least 100 cases underlying that death. And those 100 cases probably happened 2 weeks before that death. So if there were 100 cases before, then God alone knows when those cases first started. It was probably much earlier. At that stage, the government placed a lot of faith in airport screening and temperature screening. And we knew from very early stages that most people who had the disease, or many, were asymptomatic. This was known pretty early. And so the idea that airport screening could actually help in any meaningful way was just not a compelling idea. It was just not something that was going to work out. And for a country like India, at that stage, there were lots of hypotheses floating around about either heat killing the virus or people having BCG vaccines, vaccination which kills off the virus, or perhaps exposure to chloroquine, which is actually not that widespread in India. Only parts of India would use chloroquine, Orissa in the northeast, killing off the virus. There was no scientific basis for any of these because the starting point, whether for New Zealand or anyone else, is a very, very simple idea. The simple idea is that this is a novel virus to which no one has immunity. And that is the beginning and end of it. That's in a sentence which should guide all thought processes. And in fact, most questions can be answered by going back to that one sentence. And it was just trying to dance around that question that really got people to think, oh, are Indians different? Oh, but we have exposure to typhoid and all this other stuff. Maybe Indians are tougher, more immune. I mean, to a scientist, that makes no sense. I mean, this is just not grounded in any sort of. This kind of non-specific immunity is actually is not a meaningful idea. And if anything, the immune age of most Indians is actually greater. In other words, the average 40-year-old Indian, because of the amount of air pollution and poor nutrition that they've taken in, is probably of the same health and immunity as a 60-year-old Japanese person, and we know that. So if anything, Indians are worse off when it comes to dealing with the new virus. And then we had all the other issues. Comorbidities had by that time already shown to be an important issue, and India has comorbidities in heaps. Lots of hypertension and diabetes. We have undernutrition. The fact that the virus did not have a significant impact on children in China was not necessarily translatable into India, because Indian children are very different. They're disadvantaged. They're more likely to be low birth weight and undernourished early in life. So we couldn't assume that things were going to be well there. And then finally, it's just the sheer numbers. The idea of shutting out the virus was not available to India as it was to New Zealand, because India is anything but an island. We have huge flows of people coming in from other parts of the world, many of whom are Indians. And so this was just not an opportunity to really shut it down. So when I called for a shutdown in mid-March, we had 200 cases and I think about 5 or 10 deaths. And the projections that we had made were that there would be over 200 million cases, very likely, if nothing were done by May. And if there were a lockdown, we could push this caseload out. And the argument for a lockdown in India, which actually I wrote in a New York Times op-ed around that time, was never to contain the disease. It was only to postpone the disease by some time, so that we could then prepare the health system, at least to some extent, to be prepared for the wave which would follow. And I think the wave that we're seeing now is what we would have experienced 2 months ago if we had not had the lockdown. Everyone thinks that this is some sort of second surge. No, this is actually the surge after having tried to restrict transmission for a period of time. India, of course, had a 2-month lockdown. It was a harsh lockdown, but because it is in India, it was not an effective lockdown. And it can't be effective in India, again, in ways that we had described back in mid-March, which is that in places for most populations that can't socially distance or physically distance, this would always be a problem. And I think I said in that interview with Barka as well that I always was concerned about people who would have to make their daily living. And that was the big concern about lockdowns. And I think even at that time, I was not really in favor of a national lockdown. I was more in favor of state-level lockdowns, because the virus was in different states and different stages in different states. In states with international airports, there were far more cases of the virus. And there was no reason to shut down, I don't know, Bihar and the Northeast just because you have cases in Mumbai or in Tamil Nadu. It just doesn't make sense to do that. But for whatever reason, the government and system decided to shut the entire country down, and of course took on the economic damage that comes with that. But so here we are. I think the lockdown got us pretty much what we could have expected from an epidemiological standpoint. So when people say, was the lockdown a success, that's a very broad statement. It depends on what you mean by success. If you mean, did we delay the epidemic curve by 2 months? Yes, we did. Did we prepare adequately for the surge when it does happen? Yeah, to some extent, but there are some things you can't do to prepare. You can't train pulmonologists and critical care doctors in 2 months just by postponing an epidemic. Those had to happen 30 years ago, and if you didn't do that 30 years ago, then it's too late now. So I think what was possible within the Indian system, with all of its challenges, was done. And that's a neutral statement in that sense. So that's where we are right now. I mean, this this virus is about as predictable as it gets. There's no magic here. It's there's absolutely no magic here, and it's just it's a pretty straightforward. You teach students in undergrad how to model a virus to which there is no immunity. You rarely, if ever, observe that in real life, and this is a case where real life actually presented you with that example. So I'll stop.
Yeah. No, thank you. Thank you for detailed exposition. I mean, dive into both the Indian conditions and history of it, because I think it's very good to provide context. I want to say at this point that we will be taking live questions. So if anybody has live questions for either of our panelists with regard to the experience in New Zealand or some of the examples that Ramanan has just mentioned from India, we would be happy to take those. But let me take a few points from what Ramanan was saying to you, Micheal. Testing was a big issue, and the WHO kept saying test, test, test. I want to briefly understand from you, what was your testing policy? Because in India, and in many low and middle income countries, there's been a great deal of criticism of how we haven't tested enough. Now, it's one of those rhetorical questions that what is enough is something we never really find out. So what was your approach to testing at that point?
Well, there's two reasons to test. One is, you could say, epidemiological intelligence reasons to tell you about how the pandemic's progressing. And then there's testing to identify infected people so you can isolate them. And they're very different. One is a sampling approach. One is as a part of action. And for some diseases, we know that identifying cases and managing them is a mainstay of control. I mean, tuberculosis is a classic example. STIs, for instance. But for this disease, we've got a disease that is obviously there isn't a vaccine, there isn't a therapeutic drug. We are reduced to these, if you like, almost medieval interventions, and there aren't many of them. You can close borders, a kind of cordon sanitaire. You can reduce the reproduction number with physical distancing and measures like face masks to reduce the transmission risk. And you can manage cases and outbreaks with contact tracing. And your intervention is usually the same for all of these things, essentially isolating or quarantining contacts and isolating cases. So you've got these very limited techniques. So testing in New Zealand, initially, it was very much that we wanted to test every potential case, identify them, and remove them so they would not infect other people. Initially, we were limited by the testing capacity, and that was the benefit of the lockdown, meant we could build it up. So we can now test more than 10,000 people a day for a country of 5 million. So we've got a very high testing rate. And now, of course, all the tests are coming back negative, unless they're done in quarantine facilities where we are picking up people on arrival in New Zealand. They are not cases in New Zealand, and we've actually got an elimination definition, which has got these three parts to it. And it's very much the kind of concept that you use for measles and rubella elimination, the same kind of definition. That is the absence of cases for a period in the presence of a high-performing surveillance system and with logical exclusions, such as people who are sitting in a quarantine facility at the border and effectively were infected overseas. So on that basis, we've achieved elimination a few weeks ago. But we still have active cases sitting in quarantine, but they're not really, and this is the convention the World Health Organization uses, is that any case diagnosed in a country is added to the daily total, even if they're sitting in a quarantine facility at the borders. So I don't know if that covers your question.
No, it does. It does. It does. But
the other thing I'd say is now we're switching testing to basically sentinel testing of potentially exposed groups who are asymptomatic. And obviously we're testing thousands of people every day with potential symptoms and finding nothing. But it's shifted more towards people working at the border sites who may be in contact with infected travelers, just as an added precaution against importation through those settings. But it's a very different scenario from if you're managing an active pandemic in a population, then you have a completely different purpose.
Yeah, and thank you for saying that. I also want to follow this up with a question that I actually want to take to Ramanan also later. Um, one of the challenges of this of lockdowns, which both New Zealand and India implemented, were these social and economic costs. How did
Mm.
you in New Zealand address these? Because in India, one of the challenges for having a lockdown and having it long term that Ramanan was earlier mentioning were the severe economic costs in a large economy where a large section of the working population is in the informal sector. So I want to turn that to you. What was New Zealand's thinking around that, and what was your approach to it?
Mm. Yeah, well, that was a major concern. I think that's the tough thing for politicians, isn't it? It's, in some ways, for public health people, we say public health will be benefited by this course of action, and we think there's a reasonable chance that you can eliminate the pandemic. But then they have to weigh that against the economic and social harms of that. In New Zealand, the government took a very supportive approach with injecting a lot of capital into the New Zealand economy. They've actually allocated about $50 billion for that. So for a small country, it's a massive amount. And they've basically, some people have lost their livelihoods and jobs, particularly because we've got a tourist economy in parts of New Zealand. And whatever we do, the tourists have stopped coming. Of course, the cruise ships are not coming for quite a while, I imagine. So they've got a wage subsidy where they just paid money to employers who could keep people employed effectively who were not working. And so there's a whole program of things to cushion the impacts. And also, New Zealand is a wealthy country, and it has a lot of reserve capacity to afford these kind of measures.
Okay. I mean, it's interesting you say that, and let me take that question to you, Ramanan. $50 billion for a small island economy, of course, a much more affluent economy. And one of the challenges we've had in India are those terrible images of migrants, migrant labor, informal workers, migrating back to their homes, finding no way to go back. And economists like Abhijit Banerjee have spoken very clearly about the need to inject and to spend in the economy. Of course, there is the other school of thought which says this is only the beginning. The real crisis is going to be 3 months from now, because we've had large-scale joblessness in India for some months now, and the spending is long-term in any case. What do you think is the approach we need to take here in India? Because I think it's a tricky question. I know there is no one answer, but if you could reflect on that a little bit briefly.
So the first thing that was needed at a time when there was a migrant crisis was really first to have anticipated it. I think
Yeah.
it should have been, factored into the calculus. And at that time, sending migrants back to their home villages would not have caused as much transmission across states as it ended up causing, because at that stage it was still a rich person's disease. People who had traveled abroad or people who knew them. It was not really something that the poor really had. So at that stage, it could have been dealt with there. And at that stage, the issue was really about putting cash in people's pockets and making sure that no one went hungry, which could have been done and was done with using the Food Corporation of India supplies for food. Now, the challenge now is much more different, which is that the IMF now says that India will now have almost a 5% shrinking of the economy for this year, and then some rebound next year. But overall, the growth over the 2-year period will just be about 1%. And here, most countries, and in fact India included, have mostly gone for supply side interventions, not really on the demand side. And some of it is already things that are in place, like the National Rural Employment Guarantee Scheme, where a lot more people are taking advantage of it, and so that's a demand side protection. But a lot more will have to happen to ramp up demand. And the short increase in demand that we've seen over the last 2 months is really because of pent up non-spending for 2 months. So this is all very short term. And after this, we're going to see a painful period, likely, of on the economic side, and unfortunately on the disease side as well, for some time. because we'll be in this high plateau of cases for the next 4 or 5 months. So all told, it's a challenge, but it's not. I mean, it is India as it's given to. It's got all of its complexities, so you can't wish those away.
Yeah, I mean, I think I want to pick up one really critical point from what Ramanan said, and this is something, as a person who works in health, I'm witnessing all the time. There has been a wide-scale disruption of services, not just in India, but in many, many countries, cancer, TB, HIV, and I think the real health crisis in the long term is not just going to be COVID. I think it's going to be the spike in cases and the lack of access to health services that we are going to see in a lot of low and middle income countries, which we should be preparing for right now. I think our next investment should be health systems. Michael and Ramanan, we've already started getting a lot of questions. Michael, the first one I'm going to come to you with. All this talk of a vaccine, so much excitement. Somebody says 6 months, somebody says 12 months, and then the and there was talk of remdesivir. Now there are other candidates. Remember President Trump's famous statement about how everybody should be given a certain medication. We've had these challenges, and it's gone out of the arena of public health people to the political and sometimes almost the bizarre. Tell us a little bit about the vaccine, and of course there is issues associated with the vaccine, also in terms of price and access and who gets it first and who gets it later. But a little bit, if you could reflect on what we know about vaccines and what we know about cures, because the world is obsessed with them right now.
Yeah, well, look, I think the massive global effort for vaccines and therapeutics is obviously very encouraging, and I think we've got the best chance we're going to have of something coming through. The difficulty is the biology. We just don't know about very much about immunity for these viruses, and there are a number of really big challenges. I mean, there is no coronavirus vaccine yet that exists. We know that we've been unable to develop vaccines against some diseases. Obviously, HIV is the main example, a key example. And so in the end, it's been antivirals that are actually saving us from that pandemic. But they took a long time to develop the right cocktail. So obviously the technology's moved on. I do wonder if antivirals might might arrive sooner. We already have dexamethasone improving outcomes. If viral pneumonia from this agent was as treatable as most forms of bacterial pneumonia, that may actually be where we get to in the next few months. The two big challenges with the vaccines, obviously, the duration of immunity. I mean, I think immunity clearly exists, but it may be short term. And the other challenge is what level of immunity we have in older populations who are most vulnerable. And there are two big question marks. And we can look at the experience of influenza vaccine, for example, where it has its limitations. So the hope, of course, is that we do get a vaccine quickly that is highly effective and production can be scaled up. I mean, that is the best possible outcome, but we can't count on it. And I guess that's why we think that many countries should look at the containment elimination approach. And so this is, again, probably moving past your question, but if you look at a country like Vietnam and Mongolia, both countries that are emerging economies with long, complex borders, and in particular, Vietnam's case, a large, densely packed population, they have achieved elimination, containment, and I think there's very good data to support that. So I do think the elimination approach or containment should be looked at everywhere as an option. And one of the benefits is it may reduce the impact of the health and economic impact of the pandemic while we're waiting for other therapeutic options and vaccines.
Thank you so much. I mean, while you were speaking, we've had a follow-up question on this, and I have a ton of questions for Ramanan also, which are very India specific. So let me just quickly ask you this. This is by Sanjay Berry, who's saying that for the 14-day quarantine incoming travelers is being covered by the government, to your understanding, how many countries are really paying for this cost? And I think, at what stage do we expect life to go back to normal? I wonder what is normal now. We've redefined the word, haven't we? So if you could reflect a little bit on that, Micheal.
Yeah, well, I think there are some immunologists, virologists, epidemiologists who have painted some scenarios for this virus as very grim until a vaccine or therapeutics arrive, or until we can eliminate it. And that is a virus that will continue to circulate, and people will have relatively short-term immunity, maybe 1 to 2 years, and then they'll be vulnerable for reinfection. And so it won't create this idea of herd immunity, just won't happen. And even if herd immunity is possible with this virus, just through natural infection and survivors having immunity after that, it may take a very long time, because the way the virus is behaving, it may take a number of years before it circulates around the globe and has infected 60 or 70% of people. That's certainly how it's behaving. And if you look at the basic parameters, in the course of doing that, it could kill 20 to 50 million people in the course of infecting 4 or 5 billion people before it starts to actually create a level of immunity. And if that immunity is not sustained, it can just come back and reinfect people. So people like Mark Lipsitch, some of his work, I think, has painted that kind of scenario. And I don't know what Ramanan thinks of some of those scenarios, but I think they're quite grim. The other thing is the actual chronic health effects of infection seem to be more severe than was initially thought. And we do know from SARS and MERS that about 30% of people who survive have severe chronic effects. And I think for people over 40, this is quite a serious illness, even those who don't need intensive care, for example. So I'm just concerned about some of the scenarios that I think are quite plausible, looking ahead for 1 or 2 or even more years.
Yes, thank you so much. I mean, I'm glad you brought up herd immunity, because many people have been proponents of that idea, and the scale at which we seem to fail to imagine the large-scale devastation that such an approach might bring about. I mean, related to that is a question for you, Ramanan, which basically saying stalling the crisis. This is by Sadhana. She's saying stalling the crisis and preparing for it. What were primary targets of lockdown? What were the exact things the government did as a part of this preparation? Was it enough? What could have been done in this part? I mean, I guess you would have to be privy to what the government was thinking, which a lot of us were not. But based on an external analysis, what do you think?
So I do know that the government did a lot by way of procurement. Keep in mind, India went from not being a significant manufacturer of PPEs to being the world's second largest manufacturer of PPEs. There was preparedness of the procurement kind. There was preparedness of the guidelines setting kind to some extent, so that was less well done. There was some preparedness of the testing kind. Remember that on the day of the shutdown, there were probably 3,000 or 4,000 tests a day, but we emerged from the shutdown with over 100,000 tests a day. So it did scale up, even though it's still amongst the lowest in the world. It's a significant improvement. And I think different states were able to prepare differently depending on the level of expertise that they really had. There were lots of missteps in India. The chasing hydrochloroquine was probably a huge waste of time and badly misplaced. There was probably an emphasis on some ideas that just were not going to go anywhere, and serology really could have happened a whole lot before, and it just did not. But there are things which governments cannot do. You cannot, like I said, train doctors and in infection control or in critical care in a 2-month period. You just can't do that. Either they exist or they don't. So I think there was also perhaps in some places and some states a failure of imagination. But there again, it's a question of human capacity. Why is it that Tamil Nadu and Kerala and Andhra Pradesh are doing so much better, or Karnataka? Because they have the people who are able to plan, prepare. They've dealt with Nipah. They have a good health system. And as the former health secretary of Kerala said, you can't create a public health system for emergencies in the middle of that emergency. You either did it before, or you really didn't have much of a choice. So I think we're paying in many ways for the failure to invest for decades before, and that was the main limiting factor to what the government could do in the span of time.
I mean, I think I just want to emphasize what Ramanan was saying, that India has been underinvesting in health for some time now, and it's time health became a political issue, because just as we want to know whether the roads will be built or whether flyovers will be built, I think it's also time to seek accountability. If anything, this pandemic is teaching us that health has to be a core issue in public accountability and public services. And the example of Kerala is particularly good because I've worked in Kerala, and the health system is so equitable and accessible that today Kerala may be considered an example of how to defeat the virus, but really they began this fight about 50 years ago, or even longer for that matter, if you look at the public health history of Kerala. I want to also, there's one more question for you, Ramanan, before I start asking another one to Micheal, which is that India is unlocking, the positive cases are rising. This is Israel Oliver King, and the vaccine is not anytime in the future. How should India be dealing with the complexities? I think it's a very open-ended question. Let me just sort of put it down to you and say 3 key points you think India needs to do as we unlock.
There's not a whole lot that can be done. I think states are fighting the battle as best as they can, and I would not. So one thing I would not fault the government is really in terms of effort. There's a lot of effort, but the capacity doesn't exist, and outcomes depend on both capacity and effort. I agree that the vaccine is not going to happen for India for a long time, even if it happens at some global level. Just because the number of people to be vaccinated is extraordinary. We have constraints that other countries don't have. For us, you can't have a $50 vaccine and provide it to the population. It has to be much, much cheaper than that. And I think, I don't think the option of stamping out the virus ever existed for India, ever. It exists for countries like New Zealand, but New Zealand is the size of my neighborhood here in Delhi. So. And without an ocean around it. So I don't think, I think India takes a whole different level of imagination, to imagine what it is like here. So I think to some extent, we are at the mercy of the virus, and the virus will set its timelines. And if the virus is merciful, it will give us longer term immunity, which means that we'll go through one cycle. And then we'll have immunity, we'll have herd immunity, which I think is what's going to happen in India. And then the vaccine will arrive and hopefully, prevent further waves in the future. If the virus is not merciful, then we'll take a few hits. I think the point that Micheal also made about chronic effects is particularly of concern. The reason why people have, loss of taste and smell is because it obviously has some effect on neurons, which we don't understand fully well. And this is the problem when you have a brand new virus. It has impacts on human beings, which we just don't even know or understand, and we won't know for a very long time. So I think we're just going to have to, we're going to have to grin and bear it. We don't, let's also be clear, when we don't have agency over the virus, and this virus in India, we don't have that much control over.
I think that's a sobering thought. Let me also move away from sort of this and ask you a different question, Micheal. One of the key factors in controlling this virus has been public behavior, right? And you cannot just order public behavior. You have to build for it. You have to communicate for it. What was your approach in New Zealand around communications? Because that's something that countries could actually activate and learn from.
Yeah, I absolutely agree. And the communication in New Zealand, I think, has been very effective partly because of our Prime Minister has a very empathetic style of leadership, a very good communicator. And it is the classic duality, hearts and minds. And I think the communication did tap into both of those. In terms of the minds, it was presenting a coherent strategy that people could understand about getting rid of the virus, stamping it out, and that the whole country, that was the mission that we were all embarked on together. And I also think just conveying that, and I think very good social marketing that went with that. I also think there was an alert level framework, a lockdown framework, which had levels 1 to 4, and it turned out to be a very good tool because people understood what they should do at each level. And at the upper level, 3 and 4, essentially, it was quite a simple message: stay at home unless you need to go out for essential supplies. And people got that. There were also civil defence emergency powers were passed, which applied really at the highest level of containment. So that people understood it, and I think it is a manageable number of people. I mean, it's quite a small, contained population. And there was an amazingly high level of adherence. We could look at the reproduction number dropping from 2 down to about 0.4 during that period. And that basically, and we had lots of tools for looking at that. And that's really what did, eliminate the virus, essentially. But I want to go back to a question really for Ramanan, and that is about the use of face masks, because I think there's very strong evidence that they can perform almost as well as a lockdown if there's high levels of uptake. And the experience in countries is one area that there aren't of course, the controlled trial data, but there's very good, I think, observational data, and it's getting better all the time during this pandemic. That seems like the low-cost, highly effective technology that could be widely used as an alternative to lockdowns, which I think are very tough for countries. You obviously can't sustain it for very long. Is that something that is being looked at? The New Zealand experience was we don't have a mask wearing culture. People were very resistant, and also the World Health Organization didn't help by saying masks should be prioritized for healthcare workers until very recently. They just changed their policy about 3 weeks ago, and we have very limited mask use in New Zealand. We're just using it really in border settings. Some of us think every New Zealander should own a mask and know how to use it if necessary. But I'm just curious, I would have thought we've got very active transmission in parts of India. What's the place of face masks, particularly the reusable fabric ones?
Actually, this is the perfect thing for me to ask Raman, because I think there's face mask, but there is also it's a question of 3 parts. And Michael, you're talking about face masks, but actually there's a communication issue here, because in India and in various parts of the world, and WHO initially said, really, you don't need face masks. And then we got into a slightly more problematic information cycle where there was widespread confusion about who should wear a face mask. Are you infected? Are you doing it for somebody else? Are you protecting yourself from the infection? So Raman, I just want to throw those points out there before you start your answer, because I think people do want to understand this confusion a little bit.
So the reason why WHO didn't recommend face masks was they actually had compiled randomized trials, or semi quasi trials, which didn't show a huge effect of face masks. So whatever their review suggested didn't really show that they worked. India also does not have a mask wearing culture. It's kind of difficult, and in the summer heat, it's really unbearable to wear a mask. And there was also the issue that face masks and N95 respirators were bought by people who didn't really need them, compared to healthcare workers who did actually need them. So those concerns were there. Remember, we were learning from what is happening in Italy and France and everywhere else. So everyone's learning on the fly. Now, face masks, I agree with you. I think they probably have made a big difference in India. So I would not say that they are not. So if you look at states like Tamil Nadu, I would say the R naught is under 2. I mean, you could not get a disease where the R naught was about 2.5 or 2.8 in China and have a spread which is much lower. Now, India, of course, has more cases. It's just a big country, and it will continue to spread, and it's not going to get flattened out. But I would not say transmission has been as rampant in India as one would have had with absolutely no individual protections at all. I think individuals are protecting themselves. I think the transmission is slower because of that. And there are aspects of this virus transmission that we don't understand. We don't understand the fecal-oral route very well. We know that it's in sewage, and New Zealand probably has better developed sewage systems, and here there are people who are exposed to that. So we don't know the quantum of exposure through that route. We don't know the quantum of exposure in very crowded places where it's possible that masks work when everyone else is at least a 2-foot distance. But how well does a mask work if that person is, literally like right next to you, like at a liquor store here or, at a market? Does it really work then? So it's not a binary, do the masks work or do they not work? They probably work to some extent in all instances, but they may not be as effective in India for that reason. And also, there's a question of wearing a mask, right? You see most people wear a mask covering their mouths and not really, covering their nose. So if people don't know how to wear a mask, then does the fact that you just have a mask dangling, on your chin, which is where you see most masks, does that really help? Compared to Southeast Asia, where even when nothing is going wrong, people in Southeast Asia are always wearing a mask. I don't understand exactly why, but especially the tourists in India, I can understand. But Japanese people wear masks in Japan, where there's not really much of a disease risk. You see that in anime.
Yeah.
So it's a different culture, and I don't know if it's necessarily something we can adopt that easily in a short time.
I mean, I think it's a very interesting question because I think I and Ramanan are right now talking from the city, which is the biggest hotspot in India, right? Well, our caseloads are exploding. It is also the national capital, believe it or not. And we see all the time when we have to go out, if we have to go out to buy essential supplies, people with their masks dangling here. So maybe we haven't worked hard enough on that culture, because I think India didn't have that culture, and maybe we should have built that. Some of the confusion, let me turn to a broader question around this. Both of you have emphasized that this is a novel virus. We don't know enough about it. I want to ask a slightly different question. How do you see the epidemic rolling out from here? We are in the last 10 minutes. I just want to remind our viewers, if they have any further questions, they can ask them for us, to us. But I want to ask this question because I think this is a broader question. Globally and in countries like India, but also other countries that are badly affected. Micheal, I'm coming first to you. How do we see this rolling out? The WHO the last time said we could be looking at this anything between 2 to 4 years. So all this talk that we have about end of November, early January 2021, we're going to be cured here. This has an end in sight. How do we prepare ourselves? How does the world prepare itself for living with something that is not going away for the next 4 years?
Yeah, well, as I mentioned briefly, I mean, there's this range of scenarios, and some of them are really grim. And so we have to obviously include that in our planning and think, what would we do if that was the likely scenario? And that is that it is a pathogen that continues to circulate very widely in populations. It doesn't induce long-term protective immunity, particularly in the elderly. So it just keeps coming back in waves and cutting through populations, killing maybe 1% of people in each cycle and leaving a lot of other people seriously disabled. And we learn ways of dampening that down and to some extent living with it, but it's still very grim for the most vulnerable. That's one extreme, and it could take years before maybe that immunity doesn't occur and a vaccine is very hard to produce. So we probably get better antivirals that make it more survivable for those that are are seriously ill. I mean, that's probably one extreme. And then the other is that one of the vaccine candidates turns out to be very effective and arrives in quantity by, say, early next year. And then that can be given to, in a prioritized way across the globe, to the most vulnerable and healthcare workers, and then working down. I mean, you probably don't need to prioritize people, younger people, maybe at all, except as a form of population protection. If, for example, the elderly don't develop much immunity, you might, in fact, have to vaccinate young just to dampen down transmission, for example. So that's probably the optimistic end, but that's why, I do think actually that increasingly we should look at the more extreme form of suppression verging on, follow the Vietnamese model. I mean, they've achieved it with, I think, probably a similar level of, I'm not sure exactly the level of development relative to India, but that would be, I think New Zealand it's easier in New Zealand, but I think, perhaps look at what they're doing and say, can that be rolled out in India, for example? High level of mask use, high level of testing and contact tracing, and really a great deal of public engagement with the whole process, and really amongst the most successful responses in the world at the moment.
Oh, thank you for this. This is really useful. Ramanan, I'm going to ask you to comment on this in a more India-specific context, and also ask you, how do we prepare in India? We're poor on health infrastructure, we're short on health system resources, we're short of doctors, we're short of medical staff, and we're basically looking at an rapidly rising caseload across the country now.
Yeah. I'm actually not that pessimistic, and I'll tell you why. Because I think that the big thing that India has going for it is its young population. We have only 6.5% of our people above the age of 65, and about 9 or 10% above the age of 60. So in theory, it is possible for herd immunity to protect that 10% from ever getting infected, and having only anywhere between 50 and 65% infected to get to herd immunity. Now, what that level of herd immunity is, I guess earlier I thought it would be more closer to 65% based on a R0 of about 2.8. But if we have some consistent, protection measures in society because of changed behavior, and we bring that down to 2 or even slightly under, then that herd immunity number comes down to half. So that's 50% infected, and I think that India may well be at the other end of the spectrum from New Zealand. It may be one of the first countries to emerge with herd immunity. We don't know for how long, but certainly with, and remember, not everyone loses immunity at the same time. So this is it's like a level, and some people lose it. You'll still have some infections, but you won't have the kind of, epidemic that we're having right now. So as much as I was compelled to say how bad things were going to be back in March, I think I'd like to remind people now that things are not going to be as bad as they fear in 3 or 4 months from now. I think we will go through more pain, but this is not going to be a never-ending nightmare. I think we're going to emerge from it and literally the other end. And I'm less optimistic about vaccines, and I'm more optimistic probably about the antivirals. Vaccines are incredibly hard to make, and you're talking about a vaccine that has to be safe for a very large number of people, numbers of people that we've never vaccinated, in order to protect the very, very few. And these vaccines, even at the best of times, it's taken 5 years to develop a vaccine against a virus, and there are many viruses against which we've never developed vaccines. So I'm a big fan of vaccines when they work, but I'm not a big optimist about vaccines until we get one. And even then, we've got to deliver the vaccine in a country as complex as India. So I'll close by saying that, I think we'll get through this, and we'll get through this in not such a bad situation. ICMR survey from early April suggests 0.73% of Indians were infected, which would translate to about 10 million people. And at that time, the caseload was about 50,000. So in reality, with our testing levels, we are picking up 1 in every 200 people who has the disease, 1 in every 200. So today, if the number of actual counted reported cases is 500,000, it's very likely that the actual number of infected is somewhere close to 100 million people. And I'm willing to bet it's more than 50 million. I don't know exactly where it would be unless we had another serology survey. If we have 100 million people infected, we are not in that bad a situation for having had, even with some undercount, 15,000 deaths. And hopefully we can get through to the other end of this. We can't put this genie back in the box, but I think we can get to a place where there's going to be enough immunes, not in a static way, but in a sort of a dynamic way that's really going to be our main, protection against the disease. So count on young Indians, and young Indians are going to be our vaccines.
So that's an optimistic note, but I do want to exercise a bit of caution here that not all COVID-19 deaths are being counted from the ground. So I think while we are optimistic, and I certainly agree with you, 15,000 people dead is low, but I'm not sure if that is exactly the accurate figure.
Even if it's, I think we're undercounting by a factor of 3, as a matter of 3 to 4. So let's say it's 50,000 deaths. It is still, I would consider success for India at coming in less than 1.5 million deaths is actually huge success for India. Under 1 million is actually pretty good. And remember, 1 million deaths, it sounds like a big in an absolute sense. For a country of our size, we have 8 million deaths every year. So this would be, approximately another 10% increase in all-cause mortality over that period. So we would have done better than if we'd had this massive wave that just wiped out our systems, which should have happened in April or May without the lockdown. So it's all what the counterfactual is.
I know. And let me ask this one final question, which is something that is very New Zealand specific, which has come to us. Reinfection and relapse. Very briefly, Michael. My producer is waiting to shut us down. So have you seen that in New Zealand? And if so, what are your thoughts on it?
No, we haven't seen that in New Zealand. In fact, we're probably not the best place to look for that because there isn't circulating virus to reinfect people. I know there were concerns about that, and they seemed to be false concerns because people, particularly in Korea, were doing a lot of testing. So they would retest people and find traces of virus weeks or even a couple of months after their first episode. And it's partly a reflection, I think, of the high sensitivity of the testing. So I think there are still some concerns about that, and it is partly related to the duration of immunity. Even a slight question, there might be a chronic infection state. People have speculated. I don't think there's any evidence for that. So I think it's mainly an artifact of having a very sensitive test. But, time will tell. I mean, the disease has been here such a short time. The thing that will be really important will be to see if some people who have definitely been infected, have definitely cleared the virus, are then getting reinfected in 6 months or a year, and they haven't mounted a protective immune response. And that would be a worry if that actually does occur.
All right. Thank you. Thank you both for joining us today for this insightful discussion. I think this was really great because we got to learn from what New Zealand has been doing and from Ramanan's work on what what he said India should have been doing and how far down the road we are. Remember, this virus is not really going to go away tomorrow. I think there are a set of ground rules that the experts have laid out, which are fairly instructive, not just for countries, but for large-scale communities and also individuals. We have to work with these rules and see how they work. We will be focusing on the development of the vaccines and cures in possibly our next edition of these critical conversations. So till then, thank you so much both for joining us. Michael, especially to you for keeping up at night and joining this discussion. It's wonderful talking to both of you. Take care and see you next week.
Yes,